Hello and welcome to WHO Social Media Live. I'm Gaya Gamhewage, and it's my pleasure to welcome you to today's conversation. And the conversation today touches on a topic that is dear to all of our hearts. I know it's important to me, and I imagine it's going to be equally important to you. And the topic is mental health. Today I'm joined in the studio with two of my colleagues, Dr. Fahmy Hanna, he's a technical expert, and he's an expert on one very important aspect we're going to talk about, and that is mental health in emergencies, and which poses extra challenges, not just for experts, but for people who are going through this. And to my right here is Dr. Aiysha Malik, mental health specialist, and she's going to join the conversation about, I know, many topics that you might be interested in about our day-to-day mental health. I know we've seen lots of figures, we have a lot of news on mental health, so let's see how we can steer this conversation to make it useful for you. Thank you again for joining us. So let me start with you, Dr. Fahmy. Before we jump into the broader topic of mental health, I want to explain why we are actually going to talk about mental health in emergencies. This year's World Mental Health Day was on the 10th of this month, which was last Friday, and it focused on mental health in emergencies. And so, Dr. Fahmy, tell us, why should we worry about mental health in emergencies? What are the special conditions that make us look into this topic?
Thank you so much, and pleasure to be here. And we're not only today facing unprecedented humanitarian emergencies, especially when it comes to a number of people affected by humanitarian emergencies around the world, but today also we face unprecedented mental health crisis during emergencies. That's why the topic of the World Mental Health Day today is simple but urgent: access to mental health in emergencies. During humanitarian emergencies, stressful experiences are common. It's common, unfortunately, that people may lose their homes, lose their property, lose loved ones, get displaced, have difficulty in access to basic needs. Distress is also common, and most of it resolves with time. Distress include emotions such as depression, sadness, difficulty sleeping, fatigue, irritability, among many others. But also increase in mental health conditions is common. 1 in 5 people living in emergency situation have a mental health condition such as depression and anxiety, post-traumatic stress disorder, schizophrenia, and others. Today, in humanitarian emergencies, there are around 66 million people living with mental health condition in humanitarian affected countries. Also, people with pre-existing mental health condition in many emergencies today, access to mental health services is limited. In countries such as Chad, which is a huge country, there is no specialized mental health professional, while the country is facing one of unprecedented humanitarian needs. Similar situation in South Sudan, among several others. The way people cope during emergencies depend on many factors: their current mental health situation, their previous mental health situation, also their level of resilience, and the type of support they get during emergency. People with mental health condition, particularly those with pre-existing conditions such as those in institution, are among the most vulnerable in humanitarian emergencies, but sadly, because of stigma, commonly forgotten.
Yes, so this is a major challenge. I mean, WHO works in health emergencies. We estimate more than 300 million people will require humanitarian assistance. And we are working in, I think, 17 countries that require the highest level of interventions. But, you know, when you compare with supplying food or medicines or, you know, there are so many priorities in emergencies. Mental health often isn't the first thing that we used to think of. But I know with our work over the last few years, we are beginning to prioritize this. And you've been in countries, Dr. Fahmy, tell us, give us an example of what can be done and what we are doing for people in these very, very challenging situations through no choice of their own.
Guys, thank you for your question. And in humanitarian emergencies, people don't cope only with food, water, shelter, medication. People also cope with mental health and psychosocial support. When WHO is asked to support in a humanitarian emergencies, particularly large-scale emergencies, we assess the situation, identify who is on the ground, including services provided by governments, by charities, by local NGOs, and in many situations by international humanitarian workers when it comes to mental health and psychosocial support. And based on identifying who is there, we identify what are the gaps, geographical gaps in mental health care, gaps for specific vulnerable groups, gaps in specific types of services. Sometimes the gaps can be in capacity building requirements. We start building the capacities. Sometimes we start adapting and contextualizing the international standards we have. And many times we start capacity building, and many times we also have a surge capacity of deployment of experts who support the local population-owned mental health intervention. In fact, some of the biggest steps forward in mental health care during the past couple of decades come during or after mental health and emergencies. In Syria, for example, during the last decade, we have seen great advances in mental health programs. Currently, in some of the major emergencies, such as in Ukraine, we see lots of investment in mental health services scale up, using the emergency as an opportunity to scale up services.
So that's a great point. In my own public health career, I was in the tsunami in Southeast Asia.
Indeed, yeah.
And in Sri Lanka, I was there when it happened.
Yeah.
And there were hardly any mental health services.
Yeah.
But we used the opportunity of building back better.
Indeed.
And now every district in the country,
Indeed.
even districts that were not affected, have much stronger mental health care and integrated into primary health care. So actually using emergencies when we see the acute suffering sometimes is a great opportunity to do this. So I just wanted to speak to everybody and say, please use hashtag AskWHO. And some of you are also already using it to ask us questions. So we've got questions already for you. But before we go to that, Aiysha, thank you also for joining so much. So many of us have either not experienced emergencies, or we're lucky enough to have survived emergencies. But mental health touches everyone. Can you give us a sense of how big this problem is, and you know, talk us through some of the numbers we keep hearing, but each number is a person.
Absolutely. No, thank you, Gaya. I'm really happy to join everyone here today. So we published a report that I hope my colleagues will share, or it will be available if you search for it, which is called the World Mental Health Report. And in that report, we talk about how nearly 1 billion people in the world live with a mental health condition. That's an enormous number. And what's really even more important to think about is the fact that even in high-income countries, so countries that we think have lots of resources available, you've only got about a third of people living with depression who are having access to care. People living with anxiety disorders, only about 1 in 4 people get access to care. And those are the 2 most common conditions in the world. You don't have to have gone through an emergency to experience a mental health condition, as you just said, although as Fahmy is here and he has emphasised, if you live in adversity like that, it absolutely is a risk factor. But you can be exposed to a risk factor wherever you live. And we know of many risk factors that impact mental health, whether it's poverty, violence, abuse, bullying, other levels of stresses. Many things can impact our mental health. And it's basically a huge problem that we need to see more investment in, Gaya.
Absolutely. And again, you know, I want to reiterate what I said before. Nobody is untouched by this, right? We all have our stories. We all have family members. Let me just dive into the conversation, because you're getting questions. So we have a question. How can we reduce the stigma and fear around talking about mental health? Because while we understand the numbers, while we understand the need for scaling up services, there is a gap between the two still, where lots of people, and I know from my personal experience, it was frowned upon if you said, oh, I'm depressed, or I need help. So how do we deal with this stigma and this hesitancy to still talk about mental health conditions and disorders, even in 2025? Do you want to start? Yes.
Thank you, Guy. I can start, and Aiysha, maybe also you can complement. I think it's a great question. What I've seen from my work in emergencies is that usually Policymakers and people living in emergencies talk more because of the need about mental health needs and need to scale up services. And one of the first steps to take to tackle stigma is to talk about mental health, to have sessions like the one we're having right now, to share factual information and the statistic, the very fact that we can share that 1 in 5 people during humanitarian emergencies means that you are not alone if you suffer from one of these conditions or if a family member suffer from one of these conditions. So first, share information and speak about it. Second, inclusion of people living with mental health conditions when we talk and when we raise the awareness in communities, because we know by evidence that testimonials and success stories and initiatives led or participated with through people with lived experience has more impact. Also, we need to make sure we are not labeling people. We don't use terms labeling.
You mean like us, health workers,
all of us in the community,
including family members,
and including humanitarian responders. We use people first language, people living with, people having so and so.
I am not depression, but I'm living with depression.
Exactly.
Yeah.
Exactly. I fully agree. Also, I think trying to correct misconception and myths that may exist within communities by replacing with correct and factual informations. And most importantly, also by making services available in the community and normalizing the help-seeking behavior. It's okay not to be okay, but also if you are not okay, services are available and it's okay to seek service.
Need to pause on that. That's really important, right? So you talked about surfacing it by talking about it, not labeling, by including people who have the lived experience. But sometimes, and I've seen this, that people are quite complacent to say, oh, I have this, or I have anxiety, I have depression. But when I say, do you need to see somebody? Would you like? And they say, no. So that last step, I think people are beginning to acknowledge how they are experiencing it, but they're not necessarily going to get help. Is that the same outside of emergencies?
That's really interesting that we have a generation of people that knows they might be having some difficulties, but there is a hesitancy to go get the help that they might need. And I think
why is that?
Yeah, I think that hesitancy exists because there is a stigma that we have towards mental health specialists and mental health services. And one of the reasons that stigma exists is because historically a lot of care for mental health was in these, and they still exist, big institutions which come with fear attached to them. They're not places of recovery and rehabilitation for everyone. They are really places people don't want to go. Yeah. And that's why we always talk about we've got to bring services and people who can deliver care into the community. You've got to be able to go to your general practitioner in the same way that's just as normal in primary care as going to your psychologist.
So that's circling back to what you said, that in fact in some of these emergency settings where there are no institutions, the primary level or community level care, in a way, doesn't suffer from the fear of institutions, right? So I wanted to ask both of you another question. I know that in terms of health-seeking behaviors, women tend to seek help more than men. Right? And I also noticed that women tend to experience depression and anxiety, according to statistics, slightly more than men. Are these linked, or is there a difference between men and women?
That's a very interesting conversation that we could have an entire other conversation about. But I'll share a perspective on this, which is yes, indeed. If you look at the World Mental Health Report and if you look at our fact sheet on anxiety disorders, you'll see that it says women and girls are more likely to experience these conditions than people who are born male. Now, why might this be? Now, earlier I talked about risk factors, right? There are more risk factors that might impact women compared to men in many contexts. That's one part of it. So women might be more likely to be exposed to things like violence or interpersonal violence, which is an enormous risk factor for mental health conditions. Or they might be more likely to be exposed to other inequalities. So these are things which lean in the direction of items that can impact people born female. But for me, men's mental health, I think, is a very important topic, and it might be one that's not as well understood. And so what we need to do is see over time where we sit with men and what we can do to also support men to seek help as well.
So as a man and an expert, what's your view on this?
Thank you, Guy. One of the topics that was usually neglected in humanitarian emergencies, mental health response, was actually substance use during
Substance abuse,
emergencies.
yeah.
And if you get to the World Mental Health Day page, you would notice that one of our first feature stories is about an initiative WHO is launching together with UNODC and together with UNHCR, focusing on substance use during humanitarian emergencies.
Right.
How negative coping mechanism, both among the local population and even sometimes among humanitarian responders themselves, such as using alcohols or using non-prescribed medication or using drugs in some emergencies, can impact the mental health, and how people can use this as a negative coping mechanism, or sometimes due to change in the level of availability. So mental health and substance use is something that can in some countries affect men more, and is one of our priorities during humanitarian emergencies.
So it's interesting. I'm hearing you talk about like the contextual factors, right? Like violence and poverty and war and all of this. We're talking about sort of more proximal factors like access or cultural use or stress use of substances. We're looking at healthcare seeking behaviors, right? So it's really very, very complex, and maybe this is why it's difficult to have this conversation. But regardless of these risk factors, there are things we should do about it. But before we go there, there is a question. So the question is, what can doctors do to protect their mental health? But the same, humanitarian workers. I mean, I've been in really difficult situations in conflict, and we talk about protecting our mental health. We have trainings on how to protect it, but really, how can we, the helpers, the doctors, the humanitarian workers, the counselors, the frontline health workers, how can we also protect our mental health? Because obviously, if we don't, it's going to not only affect us, but going to affect the people we're going to help.
There is a lot we can do, because response to emergencies, when it comes to mental health is an integral and essential component, and in fact a mandate that countries asked us to do in the World Health Assembly, according to many WHO resolutions. So for doctors and healthcare workers, integration of mental health into general healthcare, which do have several WHO programs, such as the MHGAP program for scaling up mental, neurological, and substance use, including a humanitarian version in places where there is no psychiatrist, where there is no specialized mental health professional. General doctors can be trained to scale up services for conditions such as depression, grief, alcohol use, schizophrenia, among others. But as you rightly mentioned, Gaia, when the problem is having multiple risk factors, the way we can address it as well is multi-sectorial. So it's not only the function of health sector, while health sector have a critical role to play, but educational actors, so school mental health promotion, protection actors such as safe spaces for children, for girls, for women, nutrition actors such as behavioral activation for children with severe malnutrition through parents, and shelter and camp management and coordination. As the problem is multifactorial, the response needs to be multi-sectoral as well.
So at an individual level, Aiysha, well, you're a practitioner, and lots of people come to you, I'm sure, in your previous life, in your current life. How do you protect your own mental health when you're exposed to the suffering of others?
It's a really good question, and what I'm going to do is avoid answering for myself personally. I'll come back to it. I will come back to it.
How can one?
How can one?
Yes.
But there's a good reason for me doing this, and it's because I actually want to do a product placement. And the product placement is for our WHO guidelines on mental health at work, where one of the populations we looked at was health workers. And we were like, what is it that works for health workers to protect their mental health? And actually, it turns out it's pretty similar for what works for people in any workplace, but how you deliver it for healthcare workers needs to be a bit different. So let's say the three things we need to do are we need to prevent people from experiencing risks to their mental health at work, so shift work times, etc., etc.
Which is very, very special to us.
Very special to health workers, very special.
Yeah.
And risks, so for example, if you have a risk of, you're seeing lots of people dealing with really complex mental health problems or health conditions unsupervised, that's going to take a toll on you as a health worker. So getting supervision and supportive supervision is a way around that. The second one, which is the big piece, is managers need to be competent to not just manage, but to also support their people. You support your health workers or your employees, that's going to lead to great outcomes for them. And the third is stress management. In fact, we did, our colleagues in Ukraine delivered a stress management program that we had developed to healthcare workers all across Ukraine to help them manage the conditions that they were facing at the moment. So it's like, yes, there's stuff we can do as an individual. We can learn those stress management skills, but I always like to say other levels are important as well.
No, absolutely. But then also at individual level, we must have access to that. So if you're a manager, then there's a role for you to play, right? And it's a set of skills. It's not, I just care about my employees or the people I supervise. I must have the skills to identify and to support without harming or being intrusive. You know, as a manager, over my life, I realized more and more my role is to do that, right? And you talked about working. I mean, as a young doctor, I think I worked 105 hours a week, but that's illegal now. But during COVID, we saw how this shift work was affecting people and being separated from their families, you know, just not having a sleeping rhythm even. It reduces your ability to cope with stress, right? I think we do have a lot of health workers online. So really we wanted to say to you that this is not something extra. Looking after yourself is core to your work, you know, and healthcare workers and helpers in general tend to prioritize the person in front of us and not ourselves. And self-care is not selfish. You wanted to add something?
Thank you, Guy. I agree with what you and Aiysha has shared. For me, I also go on duty travels many times in emergency affected location. One of my ways of personal coping would be to stay connected with my family and with my friends in a moment every day. You can squeeze in time every day to strengthen your social support system to be able to cope with the stressors that work can bring. I try to keep daily routine. For me personally, also waking up and sleeping at specific time every day make a huge difference. I try to keep also some me time, such as through reading through my ebook app or through my book, where you get yourself a bit distracted from daily work related stressors.
No, that's really interesting. And what do you do?
I work out. So
physical activity.
I do physical activity. I'm a morning person,
right?
And I get up at 5:30 in the morning because I'm one of those. It's my best time. My family are.
You're the person I want to be, but yes.
Okay, that's so lovely. And then I have to exercise, and if I don't exercise, my bucket of stress is already way too full for the rest of the day.
Yeah.
So that's my personal way of doing it.
So actually, I mean, I'll share with you mine as well. But, you know, one of our viewers has said, you know, mandates and frameworks are generally well written, but it's hard to implement due to cultural hurdles. And I do agree. I come from a generation and a profession as a doctor where hard work is valued. Right? Taking time off is not valued. But it's the same even in a public health organization. Well, the legal frameworks say you should take leave and you should have your weekends. That's not how the cultural pressures work in our professions. So in a way, talking about this and coming together and figuring out how to do this and to be validated for doing that and not to be stigmatized or blamed for doing that is important. So I really appreciate the comment. Thank you for saying that, because all of these are easier said than done. You're absolutely right. And that's why we are still struggling with admitting that we need help for our own mental health, wherever on the spectrum it is, right? Because most of us are functioning well beyond what is normal. And there are cultural pressures of what we understand is normal and what is sort of indulgent, but I also wanted to just be a little provocative. And I'm sorry, you're the man here. You know, for me as a doctor, as a public health worker, now as a leader here, my day, I do want to read every night, but I go home and I cook. Yeah. I have to take care of family problems, aging parents, even though children are out of the house, you know. So I think for healthcare workers, this is the issue. And 70% of healthcare workers are women. Those who don't have power in the healthcare system, you know, less hierarchy, are women, right? Nurses and midwives and primary healthcare workers run health across the world. And they have a second job, a third job when they go home. So I think we really need to talk about some of these. And I just wanted to acknowledge that, you know, while we have these amazing frameworks and, you know, within WHO, yes, it is difficult to implement it. But men and women and bosses and employees, we should all talk about it, right?
I agree, and one of the key roles we can emphasize here in the example you kindly mentioned, Gaia, is peer support networks.
Peer support networks,
yes. I heard yesterday one of our colleagues in the emergency department sharing that as supply chains save lives, support chains save teams.
Support chain save teams. That's really interesting. Yes,
I think peer support networks are very valuable intervention here, and colleagues of females but also of males within the workplace can play a key role in supporting their peers.
Yes, so even now, in a way, this is a conversation, right? And we're having a conversation with people on our social media platforms. So it can be a point of stimulus for us to continue that conversation. In my family, what I noticed is that men wouldn't admit that they were actually undergoing stress. And when you said, would you like to see a doctor? They'd say no, you know, and the unsaid thing was, I'm a man. I don't need help. So it takes many conversations for you to hold that space to convince people that they should get the help they need. And there is more and more help available now. Would you agree, compared to the last few years, there is more help available?
I would say that there's more help available and that the information on mental health is more available and more accessible, especially since COVID. It became quite normal to talk about things. I think in the context of men, again, that you're bringing up, and what is really important for us to think about help seeking is the male suicide rate worldwide is substantially larger than the suicide rate for women. And that's a big alarm bell when it comes to this topic of help seeking. Because yes, I think many of us come from cultures where it's less likely that people of a particular gender would go and seek the help and the support that they might need. And we accidentally might all participate in contributing to that and exacerbating it and enforcing it. But actually it's a really serious issue. This is, to me, a big nut that we need to crack, is how do we communicate with people who are coming from a cultural group where seeking help doesn't feel safe to do so, because this will save lives.
Thank you, Aiysha. I think it's difficult to generalize and say that more people are able to access help now. We are in a situation where there is extreme funding constraints affecting the humanitarian community. I give you one concrete example. Last year, WHO was able, through procurements, to provide access to essential life-saving psychotropic medication during humanitarian emergencies as requested by countries to 2.1 million people living with severe mental health condition in some of the most tough humanitarian emergencies in the world. Today, this percentage in 2025 is 94% less. Not because we have less people, actually we have more.
We have less funds available.
But less funds and competing priorities make the requests by country. So while the awareness do exist, but the resources are still extremely limited.
That's a real, I mean, I think across health, we are in this crisis because of major crisis in international development and humanitarian aid.
Indeed.
And again, we go back to the beginning of our conversation, where food and shelter may be prioritized when there's only 5% of the funding that we had last year. This could be something that could be dropped. right? So we have to really keep raising the alarm on this, because mental health is health. Right? There is no health without mental health. There is a question, and I want to get that in, about how many hours, about social media and the mental health challenges that come from being constantly on social media. And it's not just being on social media for leisure, it's for our work we're on social media as well. There's a specific question, I don't know, I certainly don't have the answer, I hope you do. How many hours a day do you recommend daily for screen time to keep a stable mind? How would you respond to that?
I would say I don't have a recommendation on screen hours for stable mind. But we do have recommendations on screen time for young children, separate, I think, to social media, that comes from other experts in our organisation. And if our colleagues are able to share that information, they can. However, for the context of social media, it has both pros and cons to this time that we're spending. And I think for yourself as an individual, or the person that's asking this question, you might need to think to yourself, why are you asking this question? Is there a feeling for yourself that you are spending so long on social media that it's taking you away from other activities that you might be doing that previously might have been good for you or kept you connected with other people face to face? So I think that's an important reflection I would share back. So sorry that we don't have a specific recommendation on it.
From emergencies perspective, dealing with social media, most people during humanitarian emergencies sometimes resort to social media to get information from. And you need to make sure that you are seeking accurate information and avoiding misinformation, such as by seeking resources from reliable UN or reliable NGOs within your community, especially when it come about access to services or information about a disease outbreak, for example. But also you need to consciously limit the time you get exposed to social media during emergency, especially if you are following content which is violence or about upsetting news. Limit it to specific times when possible, and also not sharing images that can trigger emotion among people without thinking twice or without also putting warning for people.
Other people's mental health as
Exactly,
well. Yeah.
exactly.
No, thank you so much. And I just, then I'll double back just to say that, so what I do is, it's obviously directive communications is stressful in a different way than when I worked in emergencies, but it can be stressful. So in the morning I get up, I leave at least 45 minutes before I look at my phone. Usually there's more than 100 social media messages, not emails. So I found having that time is good. I meditate before I start connecting back with work, and I try to read at the weekends and be in nature. But meditation is my number one practice, because I really find the anxiety building during the day. So with that, I want to conclude, but we've talked about mental health challenges, but actually mental health is more than challenges. So we have to talk about positive mental health that allows us to do this. And I was reading WHO's report yesterday, and the thing that resonated most with me is, why do we need good mental health? So the absence of disease is not health. So why do we need health? So the first is obviously, like we're doing, to connect with each other. Our ability to have human relationships, our ability to feel empathy, our ability to belong, whether it's a peer group or a family, comes from good mental health, is required for that. And they reinforce that, right? Then the second is to function. You can't learn, you can't do a job, you can't develop without good mental health. So we must understand the impact of challenges on people's just lives throughout their lives. Then to cope, as you all talked about, how do we deal with stress and change? Change and stress are common to life. But if you have good mental health, then that is where the idea of resilience and strength comes in. And then, of course, we don't want to just live and survive. We want to thrive, right, to reach our full potential. So when we talk about mental health and we see these extreme conditions, we see these massive numbers, we mustn't forget. We said 1 billion people have mental health conditions. 7 to 8 other billion may not have good mental health. It may be they're not fully enjoying full mental health. So I want us all to think about that absence of conditions is not health, and that mental health is a conversation that we should have, not just for our knowledge, but to address stigma, to make it safe for people to talk, encourage them to seek help. So I think we should look at the full spectrum of it. I think time is nearly up. What would be your final message to our audience as we wrap up?
It's for everyone. Investing in mental health is a key way for recovery.
Yeah.
It's important during this World Mental Health Day, week and months and days to continue the value for mental health for us and for people surrounding us.
And I would say, if you look in the World Mental Health Report, there is a really nice diagram. And I'm sorry, I forgot what page it's on. But it's a diagram that shows that you can have low levels of mental health symptoms all the way to severe, and low levels of well-being to high levels of well-being. And for me, that's important, because if you live with a mental health condition, yes, you might have severe symptoms, but if you're well supported, you can have high well-being, and you can go to school, and you can go to college, and you can go to work if you are well supported. And our job at WHO, and I hope you will all join us in this advocacy as well, is to push for making sure that people can get access to the support that they need so that they can participate in life. Because people living with mental health conditions do work, do go to school, and do want to do those things. And we want to make sure that people can have access to what they need.
So this was just a tip of the iceberg. There's so much to talk about. We've had, just to let you know, people joining from Pakistan, Somalia, Nigeria, UAE, India, France, Tanzania, Bangladesh, South Sudan, Barbados, Botswana, Oman, USA, Togo, Portugal, Democratic Republic of the Congo, Croatia, Haiti, and of course, I'm sure colleagues have joined us from WHO as well. My remark is thank you so much. Thank you for joining us. Thank you for your questions. Thank you for allowing us to have this conversation. And we will see you next time in the next WHO social media live. Thank you so much. Please look after your mental health.
I had a black dog. His name was Depression. Whenever the black dog made an appearance, I felt empty and life just seemed to slow down. He could surprise me with a visit for no reason or occasion. The black dog made me look and feel older than my years. When the rest of the world seemed to be enjoying life, I could only see it through the black dog. Activities that usually brought me pleasure suddenly ceased to. He liked to ruin my appetite. He chewed up my memory and my ability to concentrate. Doing anything or going anywhere with the black dog required superhuman strength. At social occasions, he'd sniff out what confidence I had and chase it away. My biggest fear was being found out. I worried that people would judge me. Because of the shame and stigma of the black dog, I was constantly worried that I'd be found out. So I invested vast amounts of energy into covering him up. Keeping up an emotional lie is exhausting. Black dog could make me think and say negative things. He could make me irritable and difficult to be around. He would take my love and bury my intimacy. He loved nothing more than to wake me up with highly repetitive and negative thinking. He also liked to remind me how exhausted I was going to be the next day. Having a black dog in your life isn't so much about feeling a bit down, sad or blue. At its worst, it's about being devoid of feeling altogether. As I got older, the black dog got bigger and he started hanging around all the time. I'd chase him off with whatever I thought might send him running. But more often than not, he'd come out on top. Going down became easier than getting up again. So I became rather good at self-medication, which never really helped. Eventually, I felt totally isolated from everything and everyone. The black dog had finally succeeded in hijacking my life. When you lose all joy in life, you can begin to question what the point of it is. Thankfully, this was the time that I sought professional help. This was my first step towards recovery and a major turning point in my life. I learned that it doesn't matter who you are, The black dog affects millions and millions of people. It is an equal opportunity mongrel. I also learnt that there was no silver bullet or magic pill. Medication can help some, and others might need a different approach altogether. I also learned that being emotionally genuine and authentic to those who are close to you can be an absolute game changer. Most importantly, I learnt not to be afraid of the black dog, and I taught him a few new tricks of my own. The more tired and stressed you are, the louder he barks, so it's important to learn how to quiet your mind. It's been clinically proven that regular exercise can be as effective for treating mild to moderate depression as antidepressants, so go for a walk or a run and leave the mutt behind. Keep a mood journal. Getting your thoughts on paper can be cathartic and often insightful. Also keep track of the things that you have to be grateful for. The most important thing to remember is that no matter how bad it gets, if you take the right steps, talk to the right people, black dog days can and will pass. I wouldn't say that I'm grateful for the black dog, but he's been an incredible teacher. He forced me to re-evaluate and simplify my life. I learnt that rather than running away from my problems, it's better to embrace them. The black dog may always be part of my life, but he'll never be the beast that he was. We have an understanding. I've learnt through knowledge, patience, discipline and humour, the worst black dog can be made to heal. If you're in difficulty, never be afraid to ask for help. There is absolutely no shame in doing so. The only shame is missing out on life.